Hello, everyone. Today we'll be talking about management of common football injuries in season. My name is Raj Shani. I'm an orthopedic surgeon and assistant professor at the University of Texas Houston School of Medicine, and also at Hermann Ironman Sports Medicine Institute.
And I'm Leslie Bennett. I'm a licensed and certified athletic trainer. I'm with Memorial Hermann Ambulatory Outreach Group and Outreach Athletic Training, and I'm primarily at the University of St. Thomas. There we go.
We have no disclosures. So when you're talking about managing in-season injuries in the athlete, you're going to get common questions. They're going to ask you, can I play? Will I do more damage if I play? When can I play? Do I need surgery? Can I have surgery at the end of the season if I need surgery? And am I ever going to get back to the normal level of play if I do have surgery? So these are all things we'll be thinking about as managing in-season injuries. First thing we'll be talking about is shoulder dislocations. Probably one of the most common injuries you'll see in the athlete. The highest rates are in football, wrestling, and hockey. It mostly has a male predominance, and the anterior dislocation is the most common. In younger patients, you will see this happen many times. It usually has a high recurrence rate of almost 70 to 100% in some studies. The repeated shoulder dislocation long-term can lead to osteoarthritis, so this is something you want to get a good handle on as soon as it occurs. The main thing is to pick it up on the sideline. Usually it'll present with a prominent head and the shoulder will be sticking out. You'll see a lack of shoulder contour, and many they'll hold the arm inside and hold it in 80 adductor position. They'll have limited range of motion and only be able to limit it to 90 degrees of forward flexion and abduction. The mechanism usually is a fall on an outstretched arm. Usually an arm is in this position and it's pushed forward, and the arm pops out in front, as you can see in the diagrams on the slide. The main thing is to get the shoulder back in place. So first you want to examine the patient, make sure they're neurovascularly intact, and examine them and make sure there's no fractures you can palpate. And then you want to perform a reduction maneuver. I just put one on the slide right here called a Milch maneuver, and it's my favorite one. It's a very non-stressful reduction maneuver. Slowly, we gradually bring the arm up into a position, letting the deltoid relax, and then when you get into this abduction position, you provide a force upwards and inwards to feel an audible clunk and reduce the shoulder. After you've reduced the shoulder, you take the gradual range of motion, make sure you have a good reduction, and if you can, get some x-rays, which are very important to get to confirm the reduction at some point after you've done it on the sideline. You immobilize in the sling and mainly an adduction and internal rotation with the arm up in this position. Usually the duration of the sling is controversial. It comes from 3 to 4 weeks, but usually once they get their range of motion back and they feel pretty comfortable and they feel confidence on their shoulder. You want to treat this with non-steroidal anti-inflammatories and ice.
So the main thing from our standpoint is for an ATC, you want to reduce on the sidelines. A lot of times if our team physicians are there, we will go ahead and have them, but there may be a few times where this person may be at practice or even just have been sitting in class and you may need to reduce on your own. So we'll use similar techniques to what a physician will use. There may be a few times where if the athlete tenses up too much, we may not be able to do it, and those would be those few times where we send them to the emergency room. But for the most part, you can continue to play after you gain back your range of motion. For a lot of early rehab, we're looking at isometrics. We'll have them laying on the table and just focus on range of motion without pain, making sure they gain back their strength. And then as they start going, we can start doing more activities above 90. You may use some KT tape just to help with nerve firing and making sure they're going through the motions the correct way without compensation. As far as management goes, especially in football, there are a lot of braces and slings you can use. The most common type is probably going to be your Sully brace. They do have a few that actually attach to the pad, so you'll have a connection here, and it kind of limits them from going too far into the motion. So we'll probably hook here, and you'll see it limit them from going too far up, too far to the side. Usually we'll try to manage this as much as we can, and depending on what our team physician says, they'll most likely lean towards surgery at the end of this season, especially for those who are multiple recurrent, definitely more than 3 times within one season.
That's a really good point, because there's a study done by Bus et al. Look at 27 out of 30 professional athletes who did this focus rehab program, and 27 out of 30 got back within 2 to 3 weeks with the focus rehab program. So definitely for the first time dislocator, you can get them back. I just put this slide in here as a general algorithm for for understanding, what to do, when to do what. It's important that you understand the instability, what the level of dislocation is, and what the X-rays show, and if it's recurrent or not recurrent. And depending on where you are in the season and what position the player plays, we can work on getting them back in the same season. Our next topic is AC joint separation, or shoulder separations. It's basically divided into the grades. It went from grade 1 to grade 6. You can see the levels that are on the slide right there. The AC joint separation is the separation of the trapezoid and the conoid ligaments and the AC ligaments. And they can go from being very stable, in which we don't treat operatively, from grade 1 to 2, whereas grade 3 is kind of controversial when both the CC and AC ligaments are ruptured, but it's less than 100%. And then grade 4 through 6 we typically operate on. This is a very common injury in NFL athletes. About 4% of all shoulder injuries, but 97 are grade 1 to grade 2, and the quarterback is the most affected. So the quarterback will come off the sideline with their arm again held in the shoulder, adducted, and kind of wincing in pain. And the average return to play in the NFL data is for grade 1 to 2 is about 11 days, and from grade 3 it can go up to 31 days, and it's associated with some other type of injuries like slap and rotator cuff tears, or labral tears and rotator cuff tears. The acute management is, initially in rest, NSAIDs, injections, bracing. We'll talk a little about injections in a second, and physical therapy, which Leslie will talk a little bit about right now.
So basically for an AC joint, it's usually if they come off on the sideline, there's usually been some type of serious play where a player got flipped or turned over, usually some type of tackling incident. They'll usually present some kind of slumped, holding, basically some type of protective mechanism. A lot of times for this, as you can see in the slide, we'll use a brace or a padding. That way it covers up the area, should they return back, there's some kind of padding should the fall happen again. Or you can also use leukotape, which basically helps to kind of stabilize where you're at on that part, depending on your grades. Usually grades 1 through 2, we can manage pretty well. It's about pain tolerance. And like you said, grade 3 is going to be a little bit more controversial. You can obviously do rehab and prolong it a little bit, but it's honestly going to depend on that person. If their pain level is too high, or if they can't functionally get back to play without compensation, we usually tend to just rest them and either refer to the doctor for surgery and hold them in play, or just kind of stop them where they're at. For rehab, typically most shoulder injuries, you're going to start with their range of motion. We are kind of limiting below 90 degrees to give time for that proper healing. You're going to really focus on stabilization within the joint, a lot of isometrics, and then moving on to more functional skill play.
I just wanted to throw this in there. This was a study looking at the data presented at the NFL Combine, looking at the non-injection group and injection group treated with acute AC joints. As you can see here, it's a significant difference that you can get the athlete back if they are willing to consider doing a corticosteroid injection into the shoulder, into the AC joint, just to return to play quicker if you have the collegiate athlete or professional athlete that's looking for that. Our next topic is another common topic. This is injury made famous by Patrick Mahomes. He had this patellar dislocation at the end of the season last year and was able to return successfully. It occurs in 2 to 3% of knee injuries. It's equal by gender. It's most common in the second and third decades of life, usually adolescents, females, but definitely can happen in the male population too. It has a high recurrence in young patients like shoulder dislocations. The deformity is usually very obvious. As you can see on the slide here, it's a very obvious deformity of the patellar dislocated. They're unable to extend the knee, and they have a large amount of swelling in the knee that's very painful. The mechanism is, as you can see, it's a non-contact twisting injury, and it can also occur with a direct medial blow, as you've seen in most football athletes. The most important thing is the reduction maneuver and getting the patella back reduced. You want to do prompt reduction. You want to attempt get x-rays afterwards. With x-rays, you're looking for any loose bodies or any type of osteochondral ligament, osteochondral loose bodies that may have occurred with the dislocation. Usually, the initial treatment is short-term bracing, lateral J-brace, and non-steroidals and ice. But the main thing is you want to get it reduced. The reduction is usually extension with an application of a medial force to the patella.
The good thing about reducing is a lot of times this is something an athlete can do themselves. If they're a little bit nervous about the team physician doing it, you can simply instruct them to just kind of hold the patella, and as they do, try to straighten out their legs. So it's one that not only can we reduce, but they can, in a sense, self-reduce, especially if it's a little bit more frequent. For physical therapy, we do tend to put them in the brace right away. The biggest thing is going to be reduction of swelling. The next couple of days, the knee is going to start to swell throughout the joint, so you want to reduce that as much as possible. And then you're going to start right away with quad strengthening. This can be table exercises where you're simply just focusing on quad sets, getting them to fire off and be able to hold and get that strength back. Then you'll kind of move into core and hip strengthening, which is going to be a big part of helping to stabilize that and get good tracking. Once they return to play, you want to make sure that they're pain-free. You want to make sure that they can fully squat, fully do any of the motions. Their strength needs to be equal to that of the other side. So we kind of do a good job of comparing bilaterally the strength from one knee to the other. There should be no more swelling. We want to do as best as we can to keep that from limiting them in motion, and also just creating further damage as they're trying to go back to play. A lot of times we'll do testing, so we'll have them do sport-specific drills or movements to make sure that they don't have any apprehension while going through them, especially if it's a jumping sport or even if they're a receiver, quarterback, and they need to make swift moves. You want to make sure that with their twisting motions that they feel confident in making those moves. And of course, they can still continue to wear their brace while they're practicing and playing. And then from there, once the season is over, we'll refer them back to the doctor for surgical management.
So surgical management of patellar dislocations can vary. It just depends on, how often it's unstable, how much is coming off, if they have any loose bodies, and how much it really bothers them and they don't have confidence in the knee. So that's kind of once the patient comes to the office, the athlete comes to the office, we can have that discussion with them. The next topic is actually something that can be very serious and kind of scary to a lot of athletes, something known as stingers or burners. It's usually a dramatic injury to the neck and the stretch of the brachial plexus or cervical plexus of the nerves, usually a traction injury, and it causes symptoms of tingling down the arm, sometimes weakness, sometimes paralysis down the arm. It can be pretty scary and significant. Usually the athlete walks up with holding the shoulder and neck, motionless, hanging the arm down. They complain of numbness, tingling, weakness. Usually it's unilateral, and it usually lasts for a few seconds or minutes and then disappears. And it's important to get that history understanding of the temporal relationship between the injury and how long it's taken to get better and what kind of symptoms they are having. Again, this is the mechanism, that stretch injury, very common in football, as you can see on the athlete on the right and the diagram on the left. It's a dramatic force that causes the neck to go to one side over here and causes that stretching injury of those brachial plexus nerves. Again, the management is very important. You want to bring the player off, examine the shoulder, examine the cervical spine, do a good neurologic exam, make sure there's no focal deficits, make sure there's no fractures. If there's a concern, then the C-sign needs to be stabilized, and consider imaging if you have prolonged symptoms. And the main thing is to keep re-examining these athletes.
So a lot of times with the first one, we'll see them come off. They'll complain of the tingling or numbness. We'll give them a minute. We'll re-eval again. Make sure they're not experiencing any more neurological deficits. Make sure their strength is still there. And then sometimes, especially after that first incident, they can go right back in the game. It's when they start to have those reoccurring ones that we definitely refer to our physicians. Thoracic outlet syndrome is one of the key kind of things that can come about from this. And so you really want to make sure you're managing this quite well. A lot of times we have, as athletic trainers, will definitely call our team physician in for these kinds of managements, because the biggest thing is you don't want to create prolonged symptoms and have those moments lasting more than minutes or seconds. So a lot of times we just want to have them go back to pain-free motion, pain-free function. Range of motion and strength is so important. On the sideline or even in the training room, we're constantly checking for this. You can wear protective equipment and padding similar to what you would do in a shoulder dislocation. But the main thing is you're really checking those neurological symptoms and educating your patients on why it's important to always report each time they experience one. The higher recurrence rates, the more they start to have prolonged issues further down that can infect them later in life. So a lot of things we do prevention-wise, you'll see the cowboy collars come out for those, and when it keeps them just from protecting them from side-to-side motion, from moving too far. We'll do management with good head techniques, practicing heads up tackling. You'll do good stretching maneuvers, so helping them get their range of motion back, making sure if they go through motion, they're not experiencing any symptoms. And then it's just a lot of strengthening going on to help stabilize that neck. A lot of times, especially in youth sports, you just tend to get a bobblehead effects going there. So as they get older, you tend to want to get those good neck strengthening exercises going, as well as mobility within their C-spine. But always, especially in the case of reoccurrent injuries, we're always going to refer to our team physician for the final word. Because as they go on and as they start to experience this more, we want to make sure you're managing. You're not just sending them back out there blindly to have later issues.
So our next topic is going to be coming back down to the knee, looking at MCLs, which is, again, another very common injury seen in all our athletes. The MCL is a very important stabilizer of the knee, and unlike the ACL, where it's pretty much season ending, an MCL once again can be treated in season relatively well, and have most athletes get back to a very functional level of play because the MCL is extra-articular and has a great capacity to heal. Extra-articular means just outside the joint. It's classified from grade 1 to grade 3. Basically, grade 1 is just some pain with a solid endpoint. Grade 3 is a pain with just no endpoint, and grade 2 is kind of in between. It's usually a valgus maneuver with some things hit on the inside part of your knee, and it kind of goes into one direction, and it causes increased force on the medial side of the knee and an injury. Usually, it presents with pretty excruciating pain. Patients kind of walk off, and they're unable to put weight on it. And it may present with an ACL. That's why it's very important to get that exam as soon as they come off the field. And once again, most cases can be managed non-operatively. The evaluation is important. Again, the valgus stress test, test your ACL, do your Lockman examination, and we want to immobilize and a brace to try to stabilize that knee, and the timing immobilization can vary based on what the grade level can be.
So for grade 1 or 2, it's very easy to kind of stabilize them. The biggest thing in the beginning is always reduction of swelling and pain, which are going to be the most limiting factors for them, making sure they have good weight bearing, good gait control, so proper walking techniques, proper moving techniques before you try to move them back into any serious activity. A lot of times they will receive imaging if we just want to double check that there are no other circumstances like the ACL with it, which can obviously be more limiting. But if it's truly just an MCL, our biggest thing is protection, loading right off the bat, ice and compression, and then of course, moving them back into early mobilization techniques. We'll definitely work on range of motion, making sure they can extend and flex without pain, making sure they can load, especially frontal loading with football players in a ready position, making sure they can move properly and function without pain. A lot of times you'll see us do a friction massage close to the time so that as they're starting to lay down scar tissue, you can make sure the fibers are going in the correct direction along with the MCL so that they're building back up stability in that time. So range of motion exercises, lots of strengthening of the quad to support, and also the hamstring. As you can see here, there are different types of bracing. You can have ones that give you that lateral support on the side to kind of make up for where you're at, especially if it's a grade 2 and it's a couple more fibers torn. A few people will use the Luco technique, which is kind of like a McConnell tape job, but you're basically giving support to the knee on the side. And then you can also use KT tape. A lot of people are using it. Again, kind of like a extra bit of support, a cue firing to help you as you're going through movements. It's a lot less bulkier than a brace, and a lot of athletes find this more comforting. And usually, depending on your team position or just how well they're able to manage their pain, you can see them return back to play in 4 to 6 weeks, which is pretty helpful for football. It may be a little bit longer, especially if you're at a grade 3. You do want to make sure you have good control of swelling, good stabilization, good load bearing.
I really like the police acronym. That's very clever. But one thing I wanted to mention was we said that most MCL sprains heal. The one you want to watch out for is the MCL that's avulsed off the tibia. Those will not heal. Those are kind of the Stenner lesions, or they get retracted and they get interposed with some soft tissue, and those will not heal. And that's why it's very important to get the exam. Usually those are grade 3 injuries with pretty significant swelling, and That's where examination really comes in handy. Our final topic today is ankle sprains. This is extremely common. I think I have 2 or 3, 4 athletes coming a week with these, and I'm sure, Leslie, you see a lot of these in the training room. It can be divided into a lateral high and medial ankle sprains, depending on where the injuries are. Lateral, usually the ATFL or anterior talofibular ligament. It can be the peroneals. High, usually what we call the syndesmosis, between the tibia and fibula bone itself as you go higher. And then medial ankle sprains, usually the deltoid. It can be associated with fractures, instability, and subluxations. All has to be done with an exam and understanding where the pathology is. And it's very important on the sidelines, and while the game's going on, to see what happens with the athlete, how they injured their ankle, and that'll tell you a lot about what's injured, and understanding how long it's going to take to get back. When you're looking at the type of injuries, you're looking at the gait, the anatomy and stance we talked about. It can vary widely from different postural stance and where the surface is on the range of motion, what kind of shoes they're wearing, and the mechanism once again. Again, the evaluation, the first thing you want to look at is the deformity. Make sure there's no fractures. You want to palpate. You want to do an anterior drawer examination. You want to follow the Ottawa rules. And the Ottawa rules are just basically guidelines to say when an athlete should be getting an x-ray or not. So if they can weight bear, if they have tenderness, palpation, these are things that we look at as far as if they should be getting an x-ray or not, in determining whether there's a fracture. The diagnosis, once again, we grade them like we do most things for orthopedics, 1 being not so bad, partial tearing, grade 3 being complete, and grade 2 being somewhere in between. And the treatment is like all sprains, the rest, ice compression, elevation, ankle brace, the milking massage, and I think Leslie will talk a little about some of the PT that goes along with it.
Well, this is, like you said, one of the most common injuries you're going to see, not just with football, but most sports.
Yeah.
It's quite easy to kind of diagnose. You see them twist, turn. A lot of them will complain of hearing a pop, snap, and it'll either be pretty debilitating for them, or they may just walk it off really easy and be able to go back to play. So there are a few times when they present on the sideline. If they have good range of motion, if they have good mobility, you might see us just tape them up and they'll just go off on the sideline. Or there might be some that he says evaluating is really key and really important to do it right off the bat, because if they start to swell immediately, it becomes a little bit harder hours later, or even the next day when they present in the doctor's office, for us to get a really good read without doing some form of imaging. So a lot of times we like to do it right then, right there, really see where their pain is coming from before any swelling really sets in. You'll see us do milking massage for those who immediately start to swell. You really want to get it out there before it starts flowing from the ankle into the foot or into the lower extremities, and making it a little bit harder for us to get that range of motion back. Usually swelling is the most debilitating factor out the bat, but then once you get their swelling out and you manage their pain, range of motion is the first step. Lots of mobility exercises. A lot of times the dorsiflexion can be lost. So when your foot is going up, usually after they swell, they want to get stuck there, and we want to make sure they're getting their dorsiflexion back as much as they can, especially in regards to the calf and the Achilles being a support. Early functional rehab is usually what you can get away with, especially with a grade 1. Usually it's about pain. So right away, we'll get them started with stability, gait training exercises, making sure they're still walking properly and not compensating, and making sure while they're running, they are relying on both sides of their feet and not just trying to maneuver onto the opposite contralateral side. A lot of times, surgery can be postponed to the end of season if we think it is necessary. As you saw on the previous slide, the ankle has a lot of ligaments, so luckily there's a lot more support. However, it does kind of depend on the sprain. If it's a higher ankle sprain, it's a little bit harder sometimes for them pain-wise to get back, but it's not impossible, especially at the beginning of the season. So here you'll see mobility, range of motion, strength, and stability are usually our first ones. We're using bands to strengthen as they're going side to side, front and back. We're using balancing exercises to make sure they can withstand single leg exercises. So if you're thinking football and you're thinking of them moving side to side, you're thinking of them standing on one foot while somebody's attacking them, we want them to have good support. So a lot of times we'll strengthen with the band. We'll get them stretching their calves and making sure it's not tightening up and they're not losing range of motion. And we're doing a lot of dynamic stabilization exercise that mimic their sports skills. Hopping is going to be one of those things we kind of save to the end. especially game speed. We're not trying to progress them too fast, but when they get there, we want to make sure that they're still performing at a good speed and able to be stabilized. We can use tape. We can use ankle braces. It's really dependent on the person on whether they feel it's the most helpful. A lot of times I'll recommend bracing because taping does tend to kind of loosen up and get wet once they sweat, and it's not as effective as a brace, which will stay stabilized the whole time and kind of keep its shape. However, the key thing is rehab. We don't want them to become dependent on tape. We don't want them to become dependent on their brace. We just want to use it as a backup plan to what we've already been enforcing in rehab.
So we went over a bunch of injuries. There are thousands of injuries we could have talked about management in season, but these are very common injuries we wanted to kind of discuss here. And it's very challenging on managing in season management because you want to be safe for the athlete, but you also want to, get them back to play because that's what they want to do. They want to get back to play, but they want to do it safely. I believe that a focused rehab with examining them based on functional key measures are the best way to go. So it's not necessarily time, even though we get some time in weeks we want to give the athlete, but it's really going to be how they functionally respond to rehab is the best measure of when they can return. But the main thing is to do it safely and to prevent re-injury.
And for athletic trainers, we're going to do our best to get you back out there. But our most thing is we want you to return at the level that you were almost currently at. Obviously, once the joint is injured, it's never going to truly go back to the way it was, but your movement should still mimic that which you were before the injury. So we don't want to see compensations on the sideline. We don't want to see you favoring the other foot in an effort to keep going. The key thing, like you said, is safety and stability overall. So everything we do, we're going to do in phases to make sure that you understand how you should get back to sport properly.
Here's some selected references, and thank you, everybody.
Thank you.